Tell me about the study. What did you and your colleagues look at?
This was what we call a pragmatic randomized controlled trial. That means we're testing an intervention, what I call putting science to work, and you need to compare it to a control condition. Because our work was family-based and community-centered, that meant really that we had two conditions, and the goal is to add value to families that are participating, regardless of whether you're randomized to what we call the Grow Healthier group or the Grow Smarter group. So let me take you through Grow Healthier. Grow Healthier lasted for 3 years. It was what we called a tiered intervention. That means it started with weekly for 12 weeks skills building sessions with parent preschool child pairs in the community centers close to where they lived, worked, and played. So we really cared about you being in your typical neighborhood to participate. That's phase one, weekly for 12 weeks skills building sessions. We also wanted to build new social networks with families who participated. The second phase was called the maintenance phase. The maintenance phase was monthly phone call coachings with your health coach to help you identify your family's goals for better health, not just for the child, but for the whole family together. That was the maintenance phase, 9 monthly phone call coaching sessions. Then we had something called a sustainability phase. So you can see that first intensive and maintenance phase, we call that the active phase. We were reaching out to you and working more intensely with you and your family in the neighborhood and community in which you lived. The last phase, the sustainability phase, lasted for 24 months, and it was more of a passive phase. So we pushed out reminders to you. We call that cues to action. So you might get a text message, a phone call, or a newsletter reminding you what's going on in your neighborhood, in your community, so that you can be as healthy as possible for your family. So that's Grow Healthier. The Grow Smarter condition also was designed so that we could meet the needs of the community. And here this was about enhancing literacy and connecting you to the built environment of your library, your public library. In that group, you received 6 workshops to build skills about how you used your library to maximize literacy and school readiness. Again, it wasn't just for the child, it was for the participating parent and family as well. So 6 workshops to build those skills over 3 years. And then quarterly you received newsletters that were really designed to engage both the child and the parent and encourage you and teach you how to use that built environment of the library better to enhance your skills for school readiness and literacy.
And the control group only did the Grow Smarter, but the intervention group did both.
That's right, and that's why we hesitate to actually call it a control group. It was more of a comparator condition because you were receiving something that you participated in. It wasn't really a standard care type of approach. So the only difference between Grow Smarter and Grow Healthier was that the Grow Healthier condition, in addition to receiving Grow Smarter, also received the Grow Healthier components.
How many families did you look at? What ages were the kids?
610 parent preschool child pairs. And preschoolers, that meant that you were 3 to 5 years old at entry into the study.
How did you go about measuring the data?
When we looked at what was important to measure, we needed to collect data in a high quality way at 6 points over time over this 3-year process. And we wanted to collect data, as much of it to be objective as possible. So for example, to measure physical activity, you wore a small computer device on your waist so it could measure muscle movement every second of the day that you were wearing it. And that allows you to measure core physical activity, not this type of physical activity or that type of physical activity. That was an example of an objective measure. We did similar things for diet, using diet recall. We used the standard of care for diet recall to gather data on macronutrients and micronutrients. We also gathered a lot of information about your environment, how you perceived your environment, how you used your environment, parents' attitudes towards health and behavior to maximize their own health as well as their family and children's health. And we also collected some saliva so that we could look at DNA, genetics, and epigenetics.
Were the other measurements, were they self-reported by the parents? Did you guys sat them down at particular times to ask them those questions?
Yes, so those were 6 points in time asking survey questions. The reason why we focused on preschoolers is this is a really important time about how you grow. And the way that you grow will determine not only if you're healthy in childhood, but also if you're healthy into adulthood. So we call that a life course lens. And so we chose our 6 times so that we could better understand what's called adiposity rebound or BMI rebound. That meant we collected data at baseline, 3 months later, which was at the end of the intensive phase, at 9 months, 1 year, 2 years, and 3 years.
When did you measure the physical activity and the saliva?
Diet and physical activity, as well as use of your built environment and your perspectives of that, and so many other things like reports of food insecurity, depression, parental stress, also resiliency factors. These things were measured yearly. So baseline, 1, 2, and 3 years. Saliva was collected where we looked at that at baseline and then at the end of the study at 3 years. BMI and what we call anthropometry, so that's your weight, that's your height, that's your waist circumference, your tricep skin fold, those things were collected at 6 points in time.
And what did your study find?
We found that, number one, families were really engaged. They, not only were they engaged and showed up for the intervention throughout this 3-year process, but more than 90% were retained in the study at 3 years. We found that our families, they were at-risk families for poor health outcomes, obesity and other chronic conditions associated with obesity, were deeply poor. So families earned less than $25,000 a year. At baseline, 42% reported food insecurity. That's much higher. The national average is already too high, that's 20%, but our families were 42% food insecure at the start of the study. So at-risk, deeply poor families. We found that families not only were engaged, not only were retained over a 3-year period of time, but they improved their nutrition. They not only were able, we showed a difference between the intervention and the comparator condition of about 100 kcals difference, where the intervention group compared to the comparator group consumed about 100 kcals fewer a day. This was found not only at 1 year, but it was then sustained over 3 years. We also saw that we could change other behaviors, like using your community recreation center to be physically active for both the parent and the child. And this, too, was sustained over a 3-year period of time. We learned that preschoolers are built to move, and all of our preschoolers in our sample, they were physically active to a very high degree, and that finding was more than 108 minutes of moderate to vigorous physical activity a day at baseline. They remained physically active. It slowly starts to decline. So by the time you're entering school, and certainly once you enter school, the amount of moderate to vigorous physical activity declines, although it still meets more than 60 minutes per day. And for our families, it was more like 72 to 78 minutes of moderate to vigorous physical activity. This did not differ between the intervention and control condition. We see that even though we were able to create desirable, healthy behavior change and sustain that over time, that when you look at how that affects body mass index, which is what we typically use to measure obesity, that while we could slow the emergence of obesity, comparing the intervention versus the comparator group during that active intervention over that 1-year period of time, by 3 years, it was equalized, the same percentage of children emerging into obesity.
Why do you think that is?
Well, there's so much that goes into understanding obesity and effective prevention and intervention strategies. Often what we do is we look at things one at a time. We look at biology, we look at behavior, we look at environment. And we recognize that that's a false dichotomy or trichotomy. In fact, we recognize now that it's a much more complex, dynamic interaction, and it needs to be considered in an integrated way. It's not just biology, it's not just behavior, and it's not just environment. It's the interaction of these three things together. And we begin to understand the complexity of that when we look at some of the other data that we've collected over time. So we reported our primary outcome, which I just described to you, in JAMA in August of this year. We are now exploring this robust data set so that we can better answer the question that you've just asked me, which is why and what works for whom when. Because behavior change is nonlinear. We find that people change behaviors over time, but they follow their own individual path for how they get there. That requires a lot deeper study. Often when we present findings from trials like this, we put everybody together in one large pot and we mix them up and we look for the mean change over time. And we find often that when you look at mean changes, you're missing all of the complexity and individual change about what matters for whom and when. So I'll give you some examples of this. In post hoc exploratory analysis, we saw that those families, those 42% of families that started off as food insecure, that actually we were able, in post hoc exploratory analysis, to decrease the emergence of obesity in those families if you were in the intervention group compared to the comparator condition. And that leads you to ask really important questions. Why? Why were we able to help those families more than other families? And we've collected robust data, so we'll be able to dig into that so we can better answer that question. The other piece that I think is really important to understand is when you look at this complex interaction of biology, behavior, and environment, you also have to consider timing. So as we begin to look at saliva and genetics, but we think importantly the epigenetics of obesity, we already, in a proof of principle, were able to show differential DNA methylation in children at baseline, even though phenotypically they looked the same. So let me just try to say that in plainer language. So all of our children began the study at risk for obesity, but not yet obese. So that meant they were either high normal or they were overweight, but not yet obese. So that means if I have them stand on the scale and I look at their height and I look at them BMI, their body mass index, they looked the same. But if we looked at their salivary patterns, we saw biologically, even though they looked the same, physiologically, it looks like there were some potential differences already. So those are sort of the invisible things that are difficult to measure. We often say behavior, eat better, move more, sleep more, be more involved in using your built environment better so you can get to better. All those things are still true. It just isn't enough. It's one part of the story. It's understanding that interaction of biology, behavior, environment, and timing.
For families that are low income, how can they use community center as a resource? What tips would you give to parents?
We're very fortunate here in Davidson County, especially in Nashville. We had really forward-thinking mayors that doubled the number of parks and recreation centers. And these community centers were really envisioned to be the center of the community. That means here in our neighborhoods, you have freely accessible green space and playgrounds and these beautiful recreation centers that can be used for $0 to $3 to be physically active. And importantly, not one child at a time, not one parent at a time, but all together as a family. This was a paradigm shift, and we talk about this study and I say we. What I mean by we is not just Vanderbilt University Medical Center, not just the Department of Pediatrics, not just pediatricians. We're talking about partnership with community organizations that really create the infrastructure of what we can do to get to better health. And that includes parks and recreation, it includes the library, and many other really gems of our communities that allow you, if you use it better, to get to better as a family. So what does this mean for families? It means connecting to resources that exist in your built environment, your neighborhoods, and using them together as a family. And when you do that, you get to 2-generation solutions, and maybe even more than that. So you're improving children's health behaviors, parent health behaviors, and what we saw in our study, and we've got this beautiful, robust data set, so stay tuned for a lot more important findings, we see that that can ripple throughout the family.
What surprised you most about the findings?
What surprised me most? I would say, number one, that these remarkably underserved families were incredibly engaged in behavior change, in using their built environment better, striving to get to better. That's the first thing. The second is how rich it is to understand the context in which people live. That providing advice and guidance, even if it's scientifically sound, doesn't mean so much unless you connect it to the context in which people live. And that needs to be taken into account. The third finding is the secret sauce when things really work. It's not only using what you have better to get to better, but it's recognizing that our greatest resource is each other. So we didn't get a chance to talk about that. We were intentionally striving to build new social networks. So we live in a world that when we say social network, people immediately think of a technologic device. We were really talking about social networks in an old-fashioned way. That's knowing your neighbors, that's doing things with your neighbors, that's interacting with your environment, with the people that live there with you, that really share the same values of getting to better health for their families.
Are there any particular tips that you give to parents if they're looking to lower their child's risk for obesity?
When we look at what all of this means for the findings of the Growing Right Onto Wellness trial, I think when we look at prevention, we have to consider that prevention starts really early and you're never done. It's not that it's one activity that you do at one moment in your lifetime. It's something that you do throughout your lifetime. So I think we have to reconceptualize what we mean by prevention. It's a lifelong endeavor. The second part of your question is, what do we recommend for families? I will break that down into probably these essential components. Number one, when we think about children's health, we don't think about it one child at a time. We think about it as families in the context of their communities. So what does that mean for you as a parent? And if you were sitting in my office and I was seeing you and your child, I would really encourage both you and your child to set healthy habits for what you're eating, when you're eating it, with whom you're eating, and slow down. I would encourage you not just to send your child outside to play, but for you to go outside and play with your child. Not only is this joyful and fun, but it establishes healthy habits for children throughout their life, not just in childhood, but into adulthood. And extra bonus, it improves the health of the parents as well.
Anything else that you think people should know?
I would say one of the elements that we learned, and we collected something called qualitative data as well as quantitative. Sometimes we get lost in numbers. You need to mix the numbers with what they actually mean. So we collected stories and experience, the lived experience of families over these 3 years, and now we're connecting what that qualitative data helps us to understand from the quantitative finding. So I would say that one of the key things that we learned is how families are struggling and really want help from each other and from us in the medical community to be engaged as parents. We live in such a distracted world. This was one of the skills that we learned from all the pilot work that wasn't in the original study that we ended up building into the study, is how do you put all your screens away, keep it not anywhere on your body so that you can stay entirely focused on your child, yourself and your relationship together as a family. That was something that really grew out of this. The other piece that grows out of this is how important sleep is. Don't forget sleep. Often when we talk about whether we can get to better health, we think of physical activity and nutrition, critically important. But we also have to remember that getting enough sleep for both you as a parent and for your children is really critical for setting good metabolic health in childhood and throughout your life.
So basically a lot of the parents' own health really affects their kids' health.
Absolutely. You can't look at things one at a time. That's why this work is so important and so complex, because all these pieces work together. It's not improving the health one child at a time. It really is looking at children in the context of their families, striving for at least 2-generation solutions where you're lifting up the whole family to get to better health.
Anything else?
One, I'd like to pull out food insecurity. So often when we focus on behavior change, we envisioned that it's just knowledge. If only people knew, we could improve health. And what we found in our study is that our families are deeply poor, underserved families. The great majority of them already knew. They knew that they shouldn't be giving a soda to their child. They knew they shouldn't be eating French fries and pizza. They knew that. It's really about the skills, about if you only have $10 in your pocket, how do you use that better? But also the access. It's not truly choice if you don't have the same choices and the same cost accessible, high quality choices to get to better nutrition. Another piece is that when I say that word, nutrition doesn't actually mean that much to the regular average person. They're just thinking, am I hungry or not? And where is the food that is convenient that my child will eat? So teaching skills about how you look at labels, that's one part of it, but actually teaching the skills of how to cook together as a family and how to address as a society, how we create access, how we address food security, that's a critical part of the ingredients to get to better. Another element that really is important is that dynamic interaction with biology. So stay tuned for all of this really interesting research that we're finding about which switches seem to be turned on genetically even before you can measure obesity. And that means we go way back and start earlier. It also means you have to look at health across the lifespan and in what we call the life course. So what you're exposed to when, how often over time, influences later health or disease. So start early, start often, start in families and in communities.
And how early? Is it before even preschool?
Absolutely. So when we look at a life course perspective, most of my colleagues would agree that you should at least start in pregnancy and probably preconception, because health is passed on through generations. And that's why looking at these 2-generation solutions is smart, not only at this moment in time, but if we look towards the future and how we strive to get to better for everyone, and especially effectively reduce health disparities.
Could you tell me a little bit about your educational background, where you got your undergraduate, your graduate degree, and any advanced degrees?
I went to Duke undergraduate, and then I went to the University of Cincinnati College of Medicine to get my MD. After that, I did my residency at Children's Hospital of Los Angeles. And then I did a Robert Wood Johnson Clinical Scholars Fellowship at UCLA.